about are also going to be in this lecture. Objectives: discuss the different classes of anxiety, distinguish different medications used to treat anxiety, their side effects, and their safety considerations, and also talk about non-drug therapy modalities for anxiety. The classifications are listed here. You can see like anxiety can be encompassed by many different terms. We have general anxiety, panic, OCD, social anxiety, and PTSD. We're going to talk about each of them. Anxiety really is just, something that every person has experienced. There's a difference between situational anxiety, which is, you're taking a test, you're having money problems, and then there's a difference between anxiety and being diagnosed with general anxiety. Usually it's when you have it for longer than 6 months. And also, with anxiety, you can have both like physiological complaints, but also like psychological complaints. So you could have like your fear, apprehension, dread, uneasiness, and then also the physical complaints like tachycardia, your heart racing, your palms sweating, shortness of breath, dry mouth, things like that. General anxiety disorder, like I said, it's usually when it lasts longer than 6 months, and it can be, you don't really have not like unrealistic or excessive general anxiety. You may not have like a trigger or something that's caused it. Most patients that do have general anxiety disorder also have other psychiatric disorders, oftentimes depression. And of course, we're going to talk about meds here like benzos, buspirone, and antidepressants, but we also want to do non-drug therapy. Again, like, your behavioral therapy, group therapy, things like that. So the meds for anxiety that we use are benzodiazepines, so usually Xanax and Ativan. There are others, but those are 2 of the most common ones. They're best used for general anxiety disorder. They have immediate onset, so they can and are often taken PRN as needed, but you do have people that are on it like once daily, but it's usually given on a PRN basis, and it does have like immediate onset. It doesn't need to take those few weeks to build up in your system like most of the meds that we talked about on Tuesday. Its mechanism of action, it just enhances your body's response to GABA. It enhances it. It doesn't mimic it. That's going to be important when we talk about barbiturates in a little bit. So when you take benzodiazepines, you are having a CNS depression, but there is a limit to how much you can have. And that's just because it is like only enhancing it, not mimicking it. Again, they can be used for long-term use, but with that, it does have a risk of physical dependence. You can experience withdrawal symptoms, panic, paranoia, delirium. So we want to teach our patients, again, if they are on it as a daily med, to never just abruptly stop it. We're going to taper off of it if it's not an effective med, or if they're wanting to stop it. We're always going to taper. And also, it's important to distinguish between withdrawal and return of someone's anxiety. You might have someone come in complaining of these symptoms, panic, paranoia, they're not feeling great, and you just want to ask the patient, did you miss any doses? Did you forget to fill your bottle? Things like that. And if they say no, like I've been taking it as prescribed, I haven't missed anything, then that may just be their anxiety coming through, and they may need another agent. If they say, yeah, I forgot to fill my bottle last week, then, they're probably going through withdrawal. So it's just important to be able to differentiate between both of them. Another med that we use is buspirone, also called Buspar. It's an anxiolytic, just anti-anxiety, that's what that means. It is not a CNS depressant. Its effects develop slowly. Usually it takes 2 to 4 weeks to build up. So this med is given daily. It's not used as a PRN medication. It doesn't have an abuse potential. Again, for most of these meds, the mechanism of action is not really well known, but it is believed to bind to serotonin and dopamine receptors. If you do have a patient that's on benzodiazepines and they're being switched to Buspar, the benzo must be tapered down slowly. We already know this. So because the Buspar takes a little bit to build up in the system, you may be still on your benzo coming off of it while you get started on your Buspar, because the Buspar is going to be building up. It is okay to be on both of them temporarily while you're weaning down the benzo. It's well absorbed. Administration with food delays absorption but enhances bioavailability. So, it decreases your first pass effect, meaning there will be more med delivered to the bloodstream, but it may just take a little bit longer because it's being digested and metabolized with food. Its adverse effects can be nervousness, excitement, dizziness, headache, nausea. Some drug interactions: erythromycin, that's an antibiotic. Ketoconazole, that's an antifungal that patients may be on. Grapefruit juice, we know this with basically any medication. We just tell people to stay away from grapefruit juice. And then St. John's wort is like an over-the-counter herbal supplement that people believe that it helps with anxiety. So you may see your patient taking that and thinking that it's going to contribute and help, but really all four of these medications, or these 3 meds in this one drink, potentiate the effects and the level of Buspar. So you want to teach your patient to abstain from them. I don't think St. John's wort was on here, but it was in your guys' book, so I added it. That's why it may look different. Everyone okay? Again, antidepressants, like we talked about on Tuesday, they can also be used for anxiety. So you'll see that a lot. These are for long-term management, just like we talked about, like the SSRIs. They take time to build up. They're a daily medication. We don't take these PRN for anxiety. So they're often given for long-term management. They can take several weeks to take effect. This is all repetition. And you'll be on SNRIs or SSRIs, like we talked about on Tuesday. Panic disorder. So for the first time that a patient experiences this, they usually feel like they're having a heart attack or dying, if they're not, if they've never had it before. So it peaks within 10 minutes, and it can last around 30 minutes. It feels like symptoms of a heart attack. A lot of people present to the ED thinking they're having a heart attack, and it's just anxiety. Also, it's more common in women than men, and most patients that have panic disorder also suffer from agoraphobia, which is just anxiety and panic about being in places where they can't escape or in situations where they can't escape. So an elevator, at a party, they feel like they can't escape, in a line, in a crowd. This is just an overview of the panic disorder treatment. So you can see we have non-drug therapy on the side. That's like your CBT, group therapy, things like that. Exercise helps with anxiety. Also avoiding sympathomimetic drugs, like we talked about on Tuesday, like your stimulants, also caffeine and things like that. And then you can use antidepressants, SSRIs, SNRIs, MAOIs, TCAs, but again, SSRIs are going to be your first line. And then your benzos for your PRN anxiety, or also you could be on that daily too. So those are listed there, those 3 benzos. Everyone feels comfortable with the CBT, right? And we talked about the electroconvulsive therapy, the shocks and everything. Okay. So here's another list of the antidepressants that you'll see ordered for patients with panic disorder. Its effects develop slowly, like we talked about. It's a lot of repetition. And it's not used for PRN. And again, abrupt discontinuation can cause withdrawal symptoms. So you want to make sure you're educating your patient on that. OCD, so obsession is just recurrent, persistent thought, impulse, or mental image. Compulsion is a ritualized behavior in response to an obsession. Treatment for that is like non-drug therapy, psychotherapy. You'll see a lot with therapy. They'll expose the patient to their source of their fears, and they'll make them act out. They'll expose them to their fears without allowing them to act out their compulsion, which some people, it may be like washing your hands, hoarding things, and it does cause a lot of anxiety, and it is scary for the patient, but it does have a very high success rate. And then they just see they're not doing their protective rituals, and their thing that they think is going to happen, like a loved one dying or loved one getting hurt, doesn't happen. So therapy will do this like a few times, and it kind of helps the patient to see that their rituals, aren't really needed. It's very has a very high success rate, but it induces a lot of anxiety for the patient. And then for OCD, you'll mainly see SSRIs prescribed. Social anxiety disorder, everybody probably knows what that is. Intense irrational fear of situations where you're feeling like you're being judged by others. Treatment for that, again, for all of these are non-drug therapy. You always want to try that first, see if that's helping the patient. Psychotherapy, things like that. Drugs for social anxiety can be SSRIs, benzodiazepines, and then also Inderall, which I know you guys have learned about that as well, with the blocking the beta-1 and the beta-2 response that would likely kick in from your anxiety, like your increased heart rate and your palpitations and all of that. That's going to block that so the patient doesn't feel those symptoms. And then last is PTSD, post-traumatic stress disorder, develops after a traumatic event. And you have your common ones like rape, sexual assault, car accidents, but there's really no list that can cause PTSD. Trauma is whatever the patient experiences it to be. Someone may have PTSD over something that you may not feel would cause it, but it's the patient's feelings, and it's very likely that they can have PTSD from something minor. So it's characterized by 3 core symptoms: fear of experiencing the event, avoiding reminders, and persistent state of hyperarousal. And again, non-drug therapy and drug therapy. Drug therapy is usually SSRIs for that. That's it. Does anyone have any questions? It's like a lot is repeating itself. Because you can use these meds very interchangeably, and then I just have sedatives. This one also is very quick.